Well, welcome and thank you for joining what I believe will be an exciting healthcare security discussion with industry experts focused on overcoming security challenges in the changing healthcare landscape. This webinar is being recorded. This event is being sponsored by both Convergint, the global leader in systems integration, and Titan HST. Special thanks to Titan HST for their sponsorship of this webinar. Titan HST's solution is a two-way emergency mass communication platform with patented and industry-leading technology in the areas of SOS alert, mass broadcast, group chat, lockdown, safety status, and file repository. I am Chris Lutz, and I am the Vice President of the Healthcare Vertical here at Convergint. And I have about 20 years of experience in the healthcare space in pharmaceutical, medical equipment, medical device, managed care, and healthcare technology. I will be the moderator for today's panel. I'm honored to introduce our three panelists for today's discussion. Dustin Baker is the Director of Support Services for the University of Utah Health with over 17 years of experience. He is the chair of the Behavioral Intervention Team, as well as the co-chair for the creation of the Behavioral Emergency Response Team, or BERT. Jim Romagnoli was the first and immediate Vice President and Chief Security Officer for Northwell Health. He is currently the principal of Peconic Strategic Advisors, a security and crisis management consulting firm. Prior to joining Northwell, Mr. Romagnoli worked with NYPD as a detective and training specialist for 20 years. Larry Zacharies is the Vice President of Enterprise Risk Management and Chief Security Officer at Stony Brook University. He has nearly 30 years of experience in the public, private sectors, overseeing and managing multiple law enforcement and emergency management and emergency medical services and public safety organizations. Mr. Zacharies has many certifications and degrees from prestigious universities in the areas of forensic psychology, criminal justice, and international security. He's also a licensed attorney. If you have questions during the course of the discussion, please enter those into the chat function. We will have some time at the end for those. With that being said, we will start with our first question. And this will go to you, Dustin. Today's climate is becoming increasingly violent, resulting in security and safety concerns across the globe. How are you navigating and managing these new threats in your market?
Thanks very much, Chris. First off, appreciate the opportunity to be here with everybody today. This is not a new problem that we're experiencing, although I think that COVID has made this a little bit more prevalent within our environment. We noticed about probably 6 to 7 years ago, the events that we were experiencing in our health system were becoming a bit more challenging. We had a couple of events that some may recall that were in the news that gave us an opportunity to review what we were doing as a system. What we found at the time is we were very isolated, very siloed, and started to review our process and procedures, and that it really was not going to be something to be solved with one group. I started working with our chief nurse in her office and her team to really develop a better and a stronger program, multidisciplinary in approach. I started working very closely with our nursing directors to develop what we know now, and I'll talk a little bit more in a minute about our code BERT. But this is a multidisciplinary approach to manage acute behaviors. And at the time, we noticed through surveys that staff were really underreporting the types of violence and incidences that we were experiencing. We were getting reported about 20 incidences a month. However, through a better survey, we noticed that it was about 800 types of events every single month. And so as a system, we started honing in and working very collaboratively together to manage these acute incidences, which has, through many hours, has shown to reduce not just violence, but injuries in our workplace.
Thank you. And then Jim?
Yes. One of the things we saw is we took, as we saw the violent incidents increase on our campuses, we had several things that I think people might be surprised at that weren't in place. And one of those is visitor controls. We had 24-hour visitation, and you could freely pass in and out of our facilities at any time, day or night. This accounted for some of those violent incidents and other crimes on campus. What we did find by putting some structure to our visitation and identifying those that are entering the hospital for visits, vendors, or other business, that these things began to reduce. Also, it was a training issue. And like Dustin, you have to have nursing on board. I think everyone on this panel would agree, working with the chief nurse exec and her staff and nursing education, which was really where we planted our feet. We were able to better train our nurses. We were better able to give them the tools they needed to deal with either a disorderly or violent patient, many times behavioral health issues, which I know Dustin will speak to later. But outside of that, though, we also saw some of the violence on the street coming into our campuses. And in the New York area, greater New York area, hospitals were always a pretty safe sanctuary, and we kind of lost a little of that. So we tightened up some of our controls. We better equipped our offices, and we did joint training with nursing on how to restrain and de-escalate. Obviously, we want to prevent things. That's job number one. Two is job is de-escalation before we get into any physical training. So verbal judo, to steal a phrase from the NYPD, was utilized, working again with our behavioral health people and our nursing staff. We were able to get that multi-discipline approach to some of these violent incidents. So it worked well for us.
Thanks, Jim. So Larry, I'd like to get your take on it. And Jim brought up a really, interesting topic around visitor management. Maybe if you could comment on some things you're doing there to help with that as well.
Yeah, and again, thanks to the sponsors for having us, and thanks to my panelists for being here with us. It's interesting, we talk about visitor management in any medical center. Ours is somewhat nuanced, being on a campus, but not necessarily on a campus, separated by a road, literally cuts the campus in east and west. However, there are some interesting differences, having a school of medicine and having that being embedded where the medical center is. So there's the outside world and the I'll call the traditional student population mixed together. And the way that the hospital is physically structured is that people will enter the hospital to walk straight through it with no intention of ever seeing a patient or going to a clinical area to get to our health science center and our basic science tower, which are physically attached to the building. So it's an interesting complex in itself. Hundreds of doors in a 55, 60-year-old, environment has some physical security challenges. So visitor management through what I'll call the main portal, the front entrance to the hospital, has always been a challenge. But since some of it COVID and some of it just in general, as we've built out the layers of both the public safety entity, so we're lucky enough to have an embedded public safety service within the hospital, unarmed, and we've since layered our law enforcement complement on top of that. Not a bona fide hospital police service, but part of the university police department, where we're now adding, there's a deputy chief, there's two sworn inspectors. So building out some of the managerial bandwidth. So visitors management is always going to be a challenge. We've never had, I couldn't imagine 24/7 visitors. So I'm glad that Jim and his team took that one on. But we're working on identifying visitors now with managing vaccinated versus unvaccinated. So having the people in place, I agree with all the things they said about training. And what we're trying to do is, from the public safety and law enforcement side, mirror the managerial structure of the ADN with an inspector, and sort of matching that up, because it works clinically. So for us to be able to interface with them, we're building out the same exact model.
Thanks, Larry. We're going to actually stay with you for this next one as well, and we'll get thoughts from Dustin and Jim too. But top of mind for healthcare leadership must be concern around labor shortages. I saw a recent statistic that I think it was from HCA that 86% of staff in a hospital don't feel safe. So the security and safety of your staff have to be critical to attract new talent and obviously retain your employees. The Joint Commission recently released a publication in June of this year on new and revised workplace prevention requirements, and staff security and safety is one of them. How are you managing staff security and safety today, inclusive maybe of managing staff duress as well?
Yeah, it's a great question, and it is an interesting phenomenon. I think U.S. News and maybe the New York Times both called it the Great Quit. where you have this mass exodus from the workforce in general. Healthcare was already experiencing that prior to the pandemic, and now we have our frontline healthcare workers who are seeing their non-healthcare counterparts living this remote life or some hybrid life, and they just simply can't because direct caregivers have to be there. So there's that sentiment that we have to manage. There's the morale and the I won't say jealousy, that's the wrong word, but the comparisons that they make between some of their counterparts. There's the fiscal problems associated with that, who's not making what everyone else is making, but now trying to keep them in the environment and make sure it's safe. So we're heavily reliant. I'm a big tech guy, so our electronic physical security, everything from gunshot detection to increase physical patrols, and doing everything we can to layer on. Security is like the layers of an onion. The more layers you have, the better it is. I've always felt that way. So we're always looking for ways to add those on. And part of that is just outreach and education and just being physically, visibly present. In June of 2020, we had an incident where an individual walked into our emergency room with a tactical vest and some improvised explosive devices in a backpack. Obviously, you can imagine that sent waves of concern through the ER at the time and then through the whole hospital. So our forward-facing law enforcement and public safety presence was a big part of that. Just engaging, just the old park walk and talk, as it's been called. Just getting out there and people physically and visibly seeing a police and security presence has gone a long way. But I think as we continue to emerge from the pandemic and seeing hybrid work in every facet of every industry, it'll continue to be an issue to recruit and retain. Because if anyone can do some portion of it, maybe just healthcare administration, those are going to be, we're competing with the fully remote CFO jobs, right, that are out there,
right.
IT, things like that. So going to continue to be a challenge, but good old-fashioned police work and good old-fashioned presence to just take the temperature down and let people know that you're there and you're there to support them.
Thanks, Larry. Appreciate it. Dustin?
Yeah, I appreciate the question. I think this is really important and something that we've really looked at very closely for the last number of years. And what we're dealing with is a phenomenon that 15 years ago, 10 years ago, we were focused really on a patient experience. And I believe that unfortunately a patient experience has somewhat overshadowed the safety and security of that of our staff. Forever long, clinical staff and even non-clinical staff have somewhat been told in this unwritten rule that the patient is right, the customer's right, if you will. And sometimes the patients get rough and it's part of their job. We have been trying very hard to rewrite that script. And it took a couple of unfortunate events that we were able to pull out kind of our toolkit and start making presentations around options to improve the safety culture within our environment. One of that was a significant investment. When I first started in this role many years ago, more than a decade ago, we had 30 officers in our environment. Now today we're at over 135 officers. It took a tremendous investment of our hospital administration to recognize that this is very important, and it will become something that is a liability to our institution if we don't focus on. Through that investment, we were able to develop a very strong training and education program under the umbrella of the safety office. And what we've done with that is we have gone to every inpatient and outpatient area and have provided workplace violence, personal safety components as well, and as well as basic de-escalation tools for every employee. By January 1st of this next year, we will be able to have trained over probably about 12,500 people in basic de-escalation. And what are their options? And if they don't feel comfortable with de-escalation, what is their next step? Who do they call? And then that's when our BERT team comes in. It's a behavior emergency response team made up of generally 4 different people, both clinical and non-clinical. And each one of those is very dynamic, but what we've found is the show of support. I think our nomenclature's also changed. It used to be show of force. Now our show of support is able to show that we are going not to, we're not going to tolerate any of these behaviors any longer, and managing very quickly. That has preserved our staff and reduced how many people are actually leaving the workforce because they're no longer going to be in violent situations.
Thank you. Appreciate that. Jim?
So we had an interesting situation when I went to work at Northwell. we did know from US News and World Report, those numbers or similar numbers that you mentioned, Chris, that a lot of the healthcare workers thought it was an increasingly dangerous environment and that workplace violence was up, which was true. And they did not feel safe. And when we asked them why they didn't feel safe, they had no confidence in our security officers. It was the number one reason. And the reason for that, from my perspective, was we didn't look good. Every hospital had a different uniform, even though we were in the same health system, because as we did mergers and acquisitions along the way, not everything changed. Some people had some better people than others. And basically it was reviewed as a second job, a retirement job. You won't be here that long. So we did a couple things. One, we changed their appearance. And although uniform doesn't make the man, it goes a long way in giving a good appearance, to the public and instilling confidence with the staff. So we changed our uniforms. We made them more professional. We raised their salaries, and that gave us a better choice of people to pick from. We have a hybrid model where we have former law enforcement who are our armed officers. But that's another thing we did. We armed our officers and we gave them the tools they needed to do the job. And then we have other folks that aren't armed, but we're looking for college age folks who are in law enforcement, are going to go somewhere in the emergency services field. We know we're not going to hang on to that person for 20 years, but they also want to put their best foot forward. They also are very interested in the type of work. So they've turned to be a good investment. And we tell our former law enforcement people who may have completed a municipal service completion after 20 years with the police department and now do it. If you're looking for a second career, you can come and work for us. If you're looking for a retirement job, we're not looking for you. And that was very important. We took a second survey. I don't want to prolong the conversation. We did take a second survey, and the staff overwhelmingly had strong confidence in their security department and the offices within it. We changed their leadership. We changed the leadership and we increased the training. And the Health System A administration didn't realize the talent that was embedded already in the security departments. So as we made that one security department and we moved it forward with better training and better standards and better leadership, we reviewed more professionally, both internally and externally. And we've continued to try to enhance that reputation. And we've had a reduction in violence issues, and we've had a customer satisfaction increase with our staff. So, and the offices, interestingly enough, when it comes to job satisfaction, our satisfaction went up. We were the #1 rated department for employee satisfaction in the health system out of 72,000 employees. We have 650. So,
wow, that's great. So we're going to stay with you, Jim, actually, and go to another question. So I think, we've talked a little bit about the pandemic so far, right? But the COVID pandemic has certainly brought about new security and safety concerns. How has your organization evolved during the pandemic to make sure your patients, visitors, and staff are safe and secure?
So that's interesting because, again, visitors come up right in this subject, and we had banned visitors for quite a long time. With the two exceptions being end of life and a newborn birth. So, and then they were very limited stays too by the visitors. This brought tremendous animosity and created, I wouldn't say violence incidents, but disruptions with visitors when they showed up at the hospital and saw they couldn't see their loved one. So, except for those two exceptions. And our staff, this is where we saw our de-escalation training pay off. Our staff was very good, super patient with these folks, and made them understand it was for not only the safety of their newborn or their loved one that was in the hospital, but it was for their safety too. That you do not want to be in a hospital setting with a lot of sick people during a pandemic, right? And once we were able to articulate that, we did not write a script, but we did provide suggestions at our security directors meeting. We have monthly meetings with our security directors where we review their statistics. If they need help, we shift people from campus to campus. But one of the things we did was we agreed on an approach with our visitors where we would continually follow the same wording pretty much and use de-escalation to try to do it. And the vast majority of people, visitors, understood the situation and complied. And we had less and less incidents as it went along, and we slowly increased our visitation as the pandemic tapered. We increased our visitation, limited it, but still increased it, and that reduced it as well. So our staff did well. De-escalation training, verbal judo paid off tremendously during that, with the animosity we saw from visitors when they were prohibited.
Just to follow up to that real quick with you. So I would imagine, the anxiety for the visitors comes from the fact that they can't see their family member once they go to the other side, right? And did you deploy any different technologies so visitors could, or family members could communicate with staff maybe from a distance within the institution to kind of help with that de-escalation and decrease that anxiety maybe a little bit?
And that was done a lot with our nursing staff. They used their cell phones and iPads and set up links with their families. Because I have to tell you, the unique thing about the healthcare environment is, unless you're having a baby, a healthy baby, being in a hospital is probably not a good thing for your family, right? You're not, you're not there celebrating, right? Something went wrong and that's why you're hospitalized. So we have that underlying stress already. And now we compound it with, you can't see that person, right? They're already upset that they have a family member hospitalized or a loved one hospitalized. And now we're not even letting them be with them. So once we made sure our staff clearly understood some of those things and incorporated that into the training, things got better. But the nurses were able to establish communications, not on a regular basis, but enough that patients were able to speak to their families and they could see they're okay and that they're healing well. And just having been able to speak to them for 10, 15 minutes went a long way to reassuring the family that everything was okay in the hospital.
Thank you. Larry?
Yeah, just picking up right where Jim left off. We actually had early on, I'll say in the maybe March 2020, we stood up a donation center, which wound up being like a regional community donation center. And we go, you name it, we had people dropping them off. But one of the things was, I think it was, at the end, it was well over 100 iPads, maybe first or second generation iPads, but enough where there was a significant amount. And we worked with our campus and hospital IT partners, stripped those down, made sure there was, nothing of concern on it, but just got it to the point where it basically could be used, for FaceTime, and got those into the hospital and worked with social work and others to, some of them were end of life, and those were the tougher ones, but a good majority of them were just for regular, as Jim mentioned, the regular just wanted to be able to see somebody. And this was at a time when there was no visitation whatsoever. We took similar efforts as it related to sort of loosening up those restrictions as time went on, and then tightening them back down as infection. Right, we've all been on this roller coaster ride, but taking some of the goodwill of the community and then flipping it right back, and that they were dedicated. People either wanted to give PPE or things to support all of the frontline workers, or things that they could do for the patients. And taking at the time, right, we thought COVID lived on every surface and people really didn't know. So taking things into the hospital was a bit of a concern, but we worked through it with infection control and got it to where these became a staple part of the communication. Took a little bit of pressure off the clinical staff, and someone still had to be there to kind of manage it. But a phone call to the nurses station, is a lot of logistics associated with that. So this for us was good for patient satisfaction. It was good for families, and it did allow that the bridge while we were trying to figure out a good way to safely get them in at a time when we really could.
Thank you. Dustin?
Yeah, I echo exactly what Larry was saying there. I think that we had over 100 iPads that were donated to our facility, and we were able to deploy them in, very strategic areas. COVID did a couple of good things for our institution, and others that are more of a challenge. I think, as Larry said, his environment from the health system, we are exactly the same, where we are attached to an academic center from a school of medicine, that people wanted just to walk through our building. And that was a very hard balance in the beginning of COVID to tell people, sorry, look, you're not going to be able just to walk through freely within our environment. And we had at the time, I believe, 52 doors external to our environment. Most of those you could probably walk fairly freely before COVID through our facilities. Very quickly, we locked those down for very good reasons. And that's one of the good things that's come out of this is, through COVID, I'm able to secure our environment, not just because of COVID, but for the long term. We're not going to unlock those doors ever again, which creates a safer environment for everybody. We're nestled in Utah, right up on the foothills, the end of a train line. We do get a lot of homeless population that, especially during right now when we're going into the winter months, wanted to try to find refuge. We are now safer because we have a more secured environment. We've kind of ridden this wave, though. In the beginning, it was hard when we locked down visitors. Then we had this moment that healthcare were really healthcare heroes and people were celebrating the environments. And now we're back coming down the wave where folks are not loving healthcare workers. And so now we're in this third tier of how do we make sure that we're keeping our staff safe, even though we're trying to evolve through COVID, and we're trying to figure that out as we go. And there's not a right answer. But I think that the presence, and I know that Larry and Jim said this earlier, it's the presence of the people and the presence of the officers that I think that will help us long-term get where we need to be.
Thank you. Actually, Dustin, we're going to stay with you on this next question, and the topic is cybersecurity. And obviously, cyber has other colleagues within your institutions that are focused on this, but physical security is key in helping to really help manage cyber in today's environment, right? So can you just talk to me about kind of what you've done around that, and then really maybe with the focus on how you're helping to protect patient safety and privacy?
Yeah, it's interesting. In the middle of our pandemic, I don't know, you'll probably remember this. A year ago, we had a presidential election. University of Utah actually hosted the only vice presidential debate. And so going through the middle of a pandemic and then also having a VP debate on our campus actually stressed and strained our systems to make sure that we were secure and safe. Clearly the climate at the time is very difficult. And so we work very closely with a number of different groups, particularly with our IT security office, which is about 48 full-time people that their role is solely to make sure that our systems are secure. We had a huge increase, as you would expect, of folks trying to infiltrate our systems to take control of patients' information, employees' information. And we had to make sure that we could, with good reason, say that we are secure and we feel comfortable doing that. I know that we're not unique in that. Every day that there are people trying to get into our systems for one reason or another, whether it's for ransomware or whatnot. And we spend a lot of money and time to make sure that we can protect and say with good confidence that we are protecting everybody's information. It's very much a hard world right now with that.
Thank you. Jim?
Well, there's some unique things that along Dustin's answers there along those lines that you need to know. And one is, I think what we have to realize is just how valuable an intrusion would be to a bad guy, right? We probably have more information about you than a bank does. We know how to bill you. We know where you live. We know your whole medical history. We know your family history. So there's a treasure trove for a bad guy of information within healthcare. So to establish the firewalls and the safeguards that are necessary. And again, I am not a tech guy. We work closely, my office, my investigators work closely with the Chief Information Security Officer's office, and we help with the physical security end of that, as you mentioned, Chris. So that's getting harder to do as we have, and you and Larry both mentioned it earlier, a remote workforce. We literally have thousands of people out of our 72,000 working outside of the network and coming in on a daily basis in a cyber manner. So are they bringing any bad things in? So far, we've been very well. We do have hundreds, if not thousands, of attempted intrusions into our system every day. Every day someone's trying to get in. There's hackers trying to get in. So we're very confident. And once in a while we do have our breaches, but a lot of our problems are human error inside. We have the doctor who doesn't use our health system issued laptop because he doesn't like it. He likes his better. So if he starts putting patient information on there when he's at his office and not working within the hospital, then there's a possibility that our information, the health system's information regarding his patients, can be grabbed, right? So we were aggressively trying to get them to use all the devices with the built-in encryptions that we issue them. And we issue them phones, we issue them laptops, iPads, and sometimes they just prefer they own, or they're careless with it and they leave their laptop on and they leave it exposed. So we had a lot of screensaver information on logging off when you step away from your computer. We did random checks on folks to walk into an office and see if there was an unattended laptop that wasn't logged off. So we do stress it constantly, but it's an ongoing battle. It really is. There's just so many devices out there and so many people trying to get that information. So it's a cat and mouse, like many things are when you're dealing with people that are unscrupulous. It's a cat and mouse game. We put a safeguard in, they try to defeat it, we try to put another safeguard in. So it's a constant ongoing thing that's only going to increase as cyber becomes bigger and bigger in our life.
For sure. Thanks. Larry, thoughts?
Yeah, I think I heard Dustin say, I don't know, did you say 48 or 58 people dedicated to information security?
Yeah.
We have 48, yes.
As the kids say, hashtag jealous. You know, we're still building our team out. You know, 4 or 5 years ago, there was no CISO. There is now. And he has a team that continues to expand, including embedded staff at the medical center. So it's something that's a long time coming. You know, call it budget cuts, call it, you know, cultural appreciation, call it security, you know, the value engineered out and the first thing to go because it's the most expensive. It's it, right, until something happens. But a couple of, you know, close calls, couple of, you know, the Blackboard incident where a lot of people nationwide, there was a big breach on donor information. So, you know, it never wastes a good crisis. And when you see things like that happen is the time to say, now we need to, you know, continue to build out, you know, mitigation, you know, bandwidth for as it comes to cyber. So I work very closely with the CISO. Is not a direct report to me. We're, you know, I'll call it dotted lines, if you will. But my division in itself is actually new, 6 months, and sort of figuring out what the risk landscape looks like. But cyber is on the top of the list. I mean, top 3, probably oftentimes in the top spot. As it relates to threats from the outside, the insider threat is something we always are concerned about too. At a research university, R1 research, intellectual property, you know, making sure that the foreign influence is not impacting the researchers, that whether it's internal out, external in. So there's so many different moving parts, but the common denominator is information security in our cyber, you know, detection and prevention posture. We're not crawling, but we're not running super marathons yet. We're still building the team out. We're a lot better than we were, but we still have a lot more room to grow, as I think everybody.
Yeah. Well, it sounds like you said, I mean, staffing is obviously a challenge, and you obviously need a comprehensive cyber plan, right, to address the inside out threats and the outside in threats, right? There's no doubt about it. And I think you said it really well, Jim, is the healthcare institutions are probably one of the biggest cyber targets around because of the wealth of information that's housed in those institutions, right? So really important.
Without a doubt, Chris. And I don't want to prolong the subject, but one of the things, and I know Dustin and Larry are going to agree with this, is the mission of the health system is to make people better. So when it comes to getting more access controls on all of those doors everyone here keeps referring to, or buying a new MRI, they're buying a new MRI. That's our mission. That really is our mission. That's much more important than the physical security. But I think, and I know these two gentlemen, and like me, I've been able to show our security directors are now part of the leadership team at every campus and at corporate, and which they never were. But again, that came with the increasing professionalism that we put in place. But it's important that they know that it's just as valuable, right? That these safeguards are so important in a physical security sense and a cyber sense to protect it, because if there's a loss of confidence by the public with us in any way, whether it's their treatment for their health treatments, or their personal information, if we mishandle that, I have to tell you, we are in a hospital-rich environment, Larry and I, and Dustin, I know his is a renowned medical center, and any of these things could harm the reputation of the facility. and or of the company, right, so to speak. So you want to preserve that. And I know with me, Northwell saw it as equally as important. I'm not number one on the list, but I'm not on the bottom anymore either. So I do get my safeguards, but it is important because when that happens, it's usually when we have a breach, it's a newsworthy incident, and that erodes the confidence people have with us. And we don't want that, obviously.
Thanks. So one more question, then I want to go. There's a couple audience questions that came through. I want to address those as well. Last one here. This will go to you, Larry. So the Department of Homeland, this didn't scare people either, right? But the Department of Homeland Security has cited hospitals are now more than ever considered soft terror targets. Obviously, with some of the global challenges that we're seeing, I think that rings very true, right? So how are you managing that?
Yeah, I mean, I think DHS in some ways was ahead of itself, labeling the healthcare infrastructure. I remember back in the InfraGard days and early identification of the 16 critical infrastructure sectors, right? Jim and I collaborated on some of those things as well. The only thing worse than the healthcare environment is a system, and the only thing worse than that, in my case, is actually the campus environment, which is a regional resource where Stony Brook's the largest single site employer in the county. So talk about multiple layers of what it would be to make it an attractive target for the people, for the processes, for the infrastructure that it supplies. We have a train station here, we have a transit system, so multiple layers of threats. But I think I've never been a fan of the all hazards. I think it's a hackneyed term. That's just my opinion, but I think all hazards planning is important. And I think having a open aperture on all the things, our jobs as CSOs and as directors and as people who are in charge of the security mission is to think about all of the possible scenarios, even the most extreme and absurd ones, scale them accordingly, right? And then take our resources, oftentimes which are limited, and then dump them into those various buckets to try to protect us. And it's getting more and more challenging. I think if you're not leveraging technology, you're doing yourself and your organization a disservice. There's just so many people that can go around. So we have to talk about machine learning, we have to talk about AI, we have to talk about the future of just technology, but how we can use that in the security and law enforcement business. And I think if you're not doing that and using smart technology, you're making your job harder, frankly, and at some point you're going to make yourself, less and less useful and less important. So open your eyes, think about all the possible things, and then drill down to that absolute never going to happen here scenario, because we had some things recently that we never thought would happen, and realize that it's real, and that the threats are ever changing and ever evolving. And I would just say, you have to stay involved, professional development, staying involved, roundtables like this, training. Now that we're opening the world back up a little bit, going to conferences, there's so much knowledge and best practices out there. But if we keep it siloed up, it's just bad practice. So we have to be comfortable and open enough that we're going to share it with our colleagues like we're doing now. And I think that's the best defense for everybody in the industry.
Excellent. Thank you, Larry. Dustin?
Yeah, I would echo the same thing that Larry just said around silos. So what we learned, and this is one of the inadvertent good things that came out of COVID, is in Salt Lake Valley, we have a number of really large health institutions. And historically, we always viewed ourselves as competitors for good reason. And one of the things that we have learned over the last almost 2 years is that we really need each other. Historically, emergency management between the different health systems did coordinate with the State Department of EM. Security professionals and law enforcement never did. And so we have built a much stronger system over the last 2 years to collaborate and understand what each other is going through. Because the reality is that people that want to target a health system, we are pretty small still in Salt Lake City. It could be multiple systems that somebody is trying to attack. And so we have grown to be much better collaborators and partners versus competitors in our market with the different health systems. That has proved to be very effective for a number of reasons, and not just about terror attacks, but also about individuals that are physically abusive to our staff. We share patients back and forth that now that we're better able to collaborate what we're doing to try to mitigate the issues, both large and small. And as Larry said, opening up your eyes to make sure that you're not missing something. That has been something that I would urge, if you haven't, make sure that you're collaborating better with your competitors.
You're on mute, Chris. I don't think he heard your
Yeah.
call.
Chris.
That'll help if I come off mute. I was trying to make sure there was no background noise. I got a dog in here with me, so I always got to be careful with that. Jim?
Well, I'll just underscore what Dustin and Larry just said. And, I can speak firsthand, at least New York region with Larry and others. Our collaboration is very good. We share information. We had people falsely receiving treatments or drug seekers, and we share that information. I've shared it with Larry's staff. My staff has shared it with them, because we have hospitals within a mile of Larry's office, and Larry's hospital is obviously in a mile of ours. So that person doesn't get what he wants here, he's going to move down there. So information sharing, participating in groups like ACES, and sharing even information outside of the healthcare sector with large businesses and the CSOs that are running them in our region, in our service area. So that's important too, because sometimes those same types of criminals are also in healthcare as they are in other places, right? We're very worried about insider threats. We've had some insider incidents regarding some terrorist activities. We've had some of those, but working closely again with our municipal partners, they amounted to not much. But I think overall, security is omnipresence. Law enforcement's omnipresence. If you don't see it, people don't think it's there, and they'll make an attempt, whether it's there or not. So I think how you project to the public, and that you protect an air of confidence and are professional, and how you deal with them, you want someone to say, this isn't the place I should do this, right? And if you put the physical security measures and put that omnipresence in place, you will deter some activities.
Thank you. All right, so I'm going to go to some questions from the audience, and I think what we'll do is we've got 3 good ones here. So I think Larry will give this one to you. What are your thoughts on how best to communicate with personnel and visitors to manage and direct people during emergency events?
Two things, and then I'll maybe elaborate a little bit. 1, technology, and 3, multimodal. So if you're not using technology and you're not using multiple methods with which to deliver those messages, you're going to find yourself on the short end of effective crisis management, crisis communications, and you may find yourself afoul of certain regulatory requirements depending on where you are and and what you do. So there's the not legal advice, but just a tip. So I think if you don't have a way to quickly notify both an identified population, students, faculty, staff, patients, whomever, and then the unknown. So in our world, and this is the case for my colleagues, visitors are not in our emergency notification system. They're visitors. So if you don't have a way, whether it's through voice capable fire alarms or, desktop LCD, messages, RSS feeds, social media, and all those, check those boxes as much as you can. Having access to the federal government, to IPAWS, and being able to, put a perimeter around your campus for that doomsday scenario. Everyone talks about active shooter, but other things that could be an imminent threat. You have to have a few ways, not just because there's built-in redundancies are needed for the technology, but in order for you to try to reach as many people as quickly as possible with pertinent information. That's our job. It's never going to be 100%, but you do have to have good documented efforts and a robust system with which to try to get that message out. So technology, multimodal, and as many ways. And by the way, test it, right? So you don't want to blow the dust off of whether it's the policy, whether you go to log in and now you haven't logged in so long, and now you have to have 2-factor authentication, all things I've seen and heard of and experienced. So make sure you know how to use it. Make sure people know how to use it, know when to use it. Right message at the right time to the right people.
Thank you. I'm going to give this one, I think, to you, Jim, and then Dustin. I'll come to you with another question because there was one actually directly asked of you. But this one, Jim, is you're building out your cybersecurity efforts in conjunction with the CISO. Are you consulting with third-party cyber professionals to help with your ongoing efforts?
Yes, Northwell does have a third-party vendor that helps with our firewall structures and some of our deterrence measures in the cyber world. So yes, the third party is involved. We're included in the conversations with them, but they're involved with us on a daily basis.
Great, thank you. Dustin, you had mentioned earlier in one of the questions, so this is a question coming directly to you. You talked about the shift from prioritizing patient experience to staff safety and comfort. Is a paradigm shift similar to the classic debate of which comes first, the chicken or the egg, right? So the person's question is whether or not this panel sees this shift as a permanent transition, or will that priority bounce back and forth as the workforce environment pendulum swings back and forth over time?
Excellent question. I think that at the end of the day, we have become as systems much more, I think, intelligent around the patient experience. In the beginning of that, we all wanted them to rank us a 5. The reality, though, is that somebody's that's going to abuse our staff members, 2 things. They probably will never enter a survey, number 1. Number 2, if they did, they would give us a 1 anyway. And so what we've done is become a bit more savvy in the environment of honing in and focusing our environment on the therapeutic side of an environment and not waste those times trying to get that 1. And so replacing the 1 with making sure that we have proper safeguards in play. To be honest, those that are abusing our staff members, we have placed a security professional with every clinical person to go into that person's room to send a very clear message. And I don't see that pendulum going away, quite frankly. I know that speaking for our senior leadership team, they are very committed to making sure that the systems that we've built and investments that we've made, we're not going to go away from. However, still focusing on those 4s and 5s, 3s to 4s, those are very important. However, we got to make sure that we're not losing sight and going backwards into where the environment was a few years ago.
Excellent. Any other additional comments? Maybe Larry or Jim, either or on that?
No, first, Chris, I'd like to thank you and Convergint and Titan, as well as Dustin and Larry. I think we both agree we could probably talk about this for a few more hours, right? But no, there's so many things. It's a changing environment. It really is. And healthcare is as big an industry as it ever was in this country, and it's going to continue to grow. And protecting that industry is vital. And things have changed. It's not aluminum foil tape on the windows anymore, and that security guard sitting in a corner in a chair telling you which way to go. It's much more than that. It's become a truly professional service, a valuable service within the hospital, and it's going to continue to grow. And I think technology is going to help get us there too. I can't underscore enough what they said about using technology to your advantage, and it's really something CSOs and security directors across the country, really, if you're not, and believe me, I'm the last guy to be a tech guy, but I've certainly developed a great appreciation for technology. And if I had one piece of advice, I'd tell other security directors, look at the technology, look at what's out there, look at the software for you, and it will make your job easier and make your hospital a safer place.
Are you carrying a smartphone or a flip phone? That's really the question. Because if you've got a smartphone,
I know you were probably thinking flip phone, right? Chris, but no, I have my I have a smartphone.
Okay, good. All right. We've got time for another question here, and actually, I'll start with you on this one, Larry. So, as a top level security professional, obviously, you're responsible for limiting the amount of legal liability that your institution may face. So, everyone's fun topic of risk management, right? But it's important because we face it obviously in every industry, but healthcare, obviously, it's big. What advice do you have to help others avoid potential security-based lawsuits, and how do you work with your risk management colleagues to help alleviate this concern?
That's like a softball for me. So guys,
Get it up.
Yeah, so I get to, I guess, police myself, right? So this awesome new world that I'm immersed in and really building, as I say every day, building the plane while flying it halfway across the Atlantic, but it's a challenge for sure. And there are opportunities to do that. I think if you look at your structure, and are actually doing that now, and try to build it in a way that likes are with likes. And in this case, the security function, the police function, environmental health and safety, emergency management, risk management, cyber, it's all been thrown into this ever-growing bucket with the hopes to never have it overflow, but to keep expanding such that the right people and the right subject matters are being looked at by the right organization. So we're in a no-win situation such that you'll never have zero risk. So risk is going to be high, liability is going to be high. We're doing, we're in healthcare, we're in academics, we're in research. We take on the college side, we take 18-year-olds that have never been away from home ever in their life, stick 10,000 of them in our residence halls, and then feed them and have to take care of them while educating them. We have, 650, almost 700 bed medical center. We have the state veterans home. So all those things are happening. And that's the mission is to, as Jim said before perfectly, is to take care of our patients. In our case, it's take care of our patients, conduct, cutting edge research and, educate students. So trying to even out what the risk is, building, whether it's through insurance or practices and processes. It's this 360-degree look, but I'll say around a sphere, ever changing. So cyber today, probably not going anywhere for a while. That'll be there. But 4 years ago, we weren't talking about COVID-19, and then boom, we were in the middle of a global pandemic. So we switched to the public health model. But in the midst of that, we have national conversation around police and social justice. So you're pivoting towards that. So as long as you remain nimble, I think that's probably the number one quality, and always just being prepared for what comes next. Maybe somewhat surprised by it, but you're not paralyzed in your response. That's why I'm a big fan of proactive, shifting into that gear. If we do emergency management and crisis management as a life cycle, it really has no beginning and no end. So we're constantly training, we're constantly preparing. Our mitigation strategies sort of blend into those things. And then when it's time to respond, we're ready to do that. But I think it's about establishing that a culture of operational readiness lends itself to resiliency.
Appreciate that. You knew that question was going to come to the attorney.
I was ready. I was ready for it.
Yeah. I mean, there's just, yeah, right. Exactly. Dustin, thoughts on that?
No, Larry said it perfectly. I think the one thing that we also do in Utah is that to try to break down the silo, we all train together. So through the behavior intervention team, you heard that was part of my bio. We train with our attorneys. We train with our physician leaders, our risk managers, our human resources. They are part of the team, and all of the trainings that we put our security officers through, we have those folks come through it as well. They spend time in our crisis ward. They get to see the nuances that our officers go through and experience every single day. And we find that is important. So that way, when we do have an event, there's some stock that's already built up. They understand we had something we worked through just a couple of days ago, and speaking to the attorneys, they're like, well, that makes exact sense because I've seen it. They're able to have some tangible impact to understand what it is that the officers are going through every day. That gets them to a place where there's not a reaction. Then we have a better ability to respond as a system.
Excellent. Thank you. Jim, final thoughts on that topic?
Yeah, final thoughts. Like the others, we get everybody at the table. When we identify a problem that's going to result in a procedural or protocol change, we get legal involved. We have hundreds of lawyers on the second floor of our building. So there's some that are specifically assigned to corporate security. So we sit down with them. We bring in the parties that are going to be vested in this procedure or protocol, and we develop what we believe is a best case scenario. We cannot eliminate risk. We will never eliminate risk. We will reduce it. And I think that's our job, is how do we reduce our risk and still accomplish the mission? Our mission, just by nature, is there's always going to be risk. There's risk in a surgical procedure that is far greater than the risk security actions bring to the health system. So really, we don't want to make a mistake anywhere. Things do happen, and it's a matter of how much do we reduce that risk. As much as possible, we'd like to reduce that risk, and we want to do it that it doesn't impede the primary mission of patient care. Right. So those are the things. You have to get those festive parties in there. So we have good patient care going on, but we've reduced the risk as far as we could.
Excellent. Thank you. Well, Hannah and Aaron, maybe you can just, if you could bring up the final slide in case there's questions post this. But first of all, I want to thank the panelists, Jim, Larry, Dustin. Thank you for your time today, your expertise. I think it was a good discussion, and I think we hit on some really important topics. I want to also thank the audience again for joining the call today. I hope you enjoyed the discussion. If there are questions, you could see my contact information up there. And again, this session was recorded. So if you want to go back and listen to it again, or you have some colleagues that couldn't attend the session today and want to listen to the webinar, we'll have that sent out as well for everyone. But have a great day and a great rest of the week. Take care now.
Thank you, Chris.
Thank
You're
you,
welcome.
Chris.
Yeah, everyone.